going to start the chapter 81, that is the renal regulation of potassium, calcium, phosphate and magnesium. So how they are passing through the kidney, how they are filtered out, how they are excreted. Let us check out. So first, whenever there is higher potassium in the plasma, it causes cardiac arrhythmias. So actually the potassium is mainly present in our inside the cells. So in the extracellular fluid only like a very small percent of potassium is present, but sometimes in hyperkalemic conditions, like the potassium concentration may increase in the plasma. In such cases it may lead to cardiac arrhythmias, and higher concentration and means very much higher concentrations may also lead to cardiac arrest or also fibrillation. So you can understand the we should understand the importance of kidney here, because kidney whenever there is higher potassium in a body, it tries to excrete it out more, and also aldosterone is useful to excrete out most of the potassium. So let us see, only 59 milliequivalents of potassium is present in the extracellular fluid, and the intake of potassium is like around 50 to 200 milliequivalents. So if it is not removed, it may lead to hyperkalemia, or if it is low in concentration, it may lead to hypokalemia. Both may lead to certain problems, so it should be corrected. So this balance of potassium is maintained by our kidneys. So input and output of potassium should be regulated properly for the homeostasis, of course. So the input so the potassium excretion. So let us see how the potassium is excreted out. The rate of potassium, it is dependent on the rate of potassium filtration, that is the glomerular filtration rate of potassium into the plasma concentration. So the glomerular filtration rate of potassium is 756 milliequivalents, and the plasma potassium concentration is 4.2, and it is also dependent on the rate of reabsorption and also on the rate of secretion. So let us discuss it one by one. So first, for example, if there is low glomerular filtration rate for potassium, then potassium start accumulating in the body tissues. So this leads to hyperkalemia. So in the blood, whenever this potassium is high in blood, it is called as hyperkalemia. So if the GFR, the filtration is low, means it is getting absorbed, it is more in the blood, it is leading to hyperkalemia. And the 65% reabsorption of potassium is normally done in our proximal convoluted tubule, and 25 to 30% of reabsorption is done in our ascending thick part of loop of Henle, and some potassium is also reabsorbed in the collecting tubule. So you can see most of the reabsorption of potassium is on a proximal convoluted tubule, and somewhat medium by ascending thick part of loop of Henle. So how potassium goes into the cell. In the previous we have seen 65% of sodium, 65% of potassium, how it goes into the cell. And the principal cells and late distal convoluted tubule and cortical collecting tubules have sodium potassium ATPases in the basolateral membrane. So this one I'll explain this by means of diagram so that you can understand easily. So here you can see this is the basolateral membrane side and this is the lumen side. So actually in the basolateral membrane of you can take example of the last cell, the collecting tubule cells. So they have on the basolateral side, they have sodium potassium ATPases. On the luminal side, they have this kind of different channels, BK, ROMK, ENAC. So actually what happens is, whenever the aldosterone comes and it activates them, sodium and water are reabsorbed. So before that we need to see what is going. The sodium potassium ATPase, what it does is takes the 3 sodium out from the cell, that is into the interstitial fluid, and it brings 2 potassium into the cell. So this potassium is inside the cell now. So now this potassium which has come into the cell by means of this sodium potassium ATPase, it will get excreted out by means of these channels here. Excreted means secreted. They are secreted into the lumen side. This is the tubular lumen side. So they will be secreted into the lumen. So as they are secreted in the lumen, if secretion is done in the tubular lumen, means it is going to be excreted. So lot of potassium, because of production of the different channels, you can see ROMK, BK, all these channels you can see they are like sending out the potassium out. And sodium, you can see the further sodium is coming inside, it's not it's going inside. So because aldosterone function is to reabsorb the sodium and water, so they create this kind of channels like ENAC. So these all promote the reabsorption of sodium, water. Of course, if sodium goes, water follows it. So as sodium goes in, even water follows along with it. So like this, from this again by means of sodium potassium ATPase, sodium gets into the interstitial fluid and potassium comes outward and gets excreted. So this is a process of excretion of potassium which is going on in the last part of our that is our in our late part of distal convoluted tubule, and also especially the principal cells of late DCT, and also in the cortical collecting tubules. So this process is going on. So the factors which increase this potassium excretion are whenever there is of course extracellular fluid of potassium concentration. If our body finds there is lot of extracellular fluid potassium, then it immediately activates this kidney cells to excrete more potassium out. And whenever there is of course high aldosterone, we have seen just now the process, what happens if more aldosterone is higher tubular flow rate, also it will lead to increase in potassium secretion, because whenever there is higher flow rate, this channels like BO, BK, ROMK, which are transporting the potassium towards the tubular luminal side, though this also will increase. And even in the case of alkalosis also, this will lead to increase in potassium secretion. Now let us see what will decrease the potassium secretion, mainly whenever there is higher hydrogen ions. So higher hydrogen ions is nothing but acidosis case. So in acidosis case also we will see there is low potassium secretion is nothing but a lot of the potassium is getting reabsorbed, it is not getting excreted. So in acidosis, in acute acidosis, mainly we will see the reabsorption of potassium is increased. Why it is increased? Because the sodium potassium ATPase pump is decreased. So if the sodium potassium ATPase pump is decreased, then the potassium will only not get accumulated in the cell. And because of this, the potassium concentration inside the cell decreases, and also there is decreased potassium channels. So as the potassium channels also decrease, the potassium have no chance to come out into the tubular lumen side. So in chronic, so this is an acute acidosis case, but coming to the chronic acidosis case, you can see there is loss of potassium due to more load to the DCT. In chronic acidosis, actually what happens is lot of potassium is lost into the urine, means it is getting excreted out because there is more load to DCT, because the sodium and water absorption at the proximal convoluted tubule is decreased in the case of chronic acidosis. So this you need to observe. So chronic acidosis also comes under this case, that is the factor which increases the potassium secretion. Next, let us see what are the beneficial effects of diet which is having higher amount of potassium. Normally the sodium level in our diet should be low, whereas the potassium level in our diet should be high and low in sodium content. So this the people who are like having high potassium diet and low sodium content, they are having no cardiovascular diseases. So it's better to have high potassium in your diet when compared with sodium. So if there is higher sodium, like in our lifestyle we eat more salty food and we have low potassium in our food, so this may lead to, in future it may lead to, if we are continuing this, it may lead to hypertension, many cardiovascular diseases, many kidney diseases. So to prevent all this, it's better to eat more potassium rich food when compared with sodium food. So eat only like normal value of salt that we need to eat per day is just 1.5 gram per day, but how much we eat we don't know. And also increase in potassium 4.7 grams. So you can eat like potassium 4.7 grams per day, but salt you need to eat only 1.5 gram per day. So now let us see the control of calcium excretion and extracellular fluid calcium concentration. So we have understood about the potassium, how its concentration, how it's getting excreted. Now let us move on to calcium. So before going to calcium, we have some of the important diagrams regarding potassium to understand. So here from our textbook you can see if you are having potassium intake, you can see the potassium concentration in the blood increases, and aldosterone concentration can also increase the potassium, so it will lead to potassium excretion. Of course, if there is more potassium in a blood, it will finally lead to excretion. And here we can see whenever there is higher potassium intake, the plasma potassium concentration will rise. This will in turn lead to rise of potassium secretion in the cortical collecting tubules. Of course, this will lead to increase in potassium excretion. Even aldosterone also amplifies the excretion of potassium. So next one is sodium intake. how sodium intake, what it does, let us see. So sodium intake mainly decreases the aldosterone and it increases the GFR. So if the aldosterone is decreased, means potassium excretion is also decreased, of course. It increases the GFR and the proximal tubular sodium reabsorption decreases. Means in the PCT the sodium reabsorption is decreased, so that there is increase in distal tubular fluoride. So all this together, this distal tubular fluoride is a positive action for the potassium secretion cortical collecting ducts. So potassium is secreted and unchanged potassium excretion. Whereas if it is having a negative aldosterone, you can see decreased aldosterone means potassium secretion of cortical collecting duct. Here also it is having unchanged potassium excretion. So this is why if we take more sodium in our diet, you can see the reabsorption of sodium is decreased, means sodium is getting excreted out, and the distal tubular fluoride is also increasing, and potassium secretion cortical collecting ducts is positive in the case of this, it's negative in the case of aldosterone. Finally there is unchanged potassium excretion. Now let us check out the control of calcium excretion and extracellular calcium concentration. So if the calcium is low, it is called hypocalcemia, that is in a blood. If the calcium is low, the condition is hypocalcemia. So because of hypocalcemia, there will be higher excitability of nerves, muscles, and results in hypocalcemic tetany. So by spastic muscle contractions in skeletal muscles. So whereas in hypercalcemia, means if there is higher calcium in blood, it will lead to depression of neuromuscular excitability and also lead to some arrhythmias. So 50% calcium actually is in the ionized form, whereas the plasma bound calcium is like about 40%, and in non-ionized form we have only 10% of calcium. So you can see the plasma bound calcium means it can't pass into the kidney, whereas ionized form it can pass, and even a non-ionized form can pass. So acidosis means hydrogen ion concentration increase. So in that case calcium bounding to the plasma protein will decrease. So means you can understand in acidosis case there will be higher excretion of calcium or higher passage of calcium into the kidney, right? And in alkalosis reverse, means in alkalosis case the plasma protein will leave the calcium, means they are bound very tightly. So means they can't pass to the kidney in that case. So alkalosis may lead to hypocalcemic tetany. Why alkalosis will lead to hypocalcemic tetany? Because alkalosis means higher plasma protein is bound to the calcium, means calcium is not available to the body tissues. If the calcium is not available, decreased calcium, it will lead to we have seen if there is decreased calcium, it will lead to nerve and muscle excitability, that is hypocalcemic tetany. So that will lead to hypocalcemic tetany. So GI system, actually calcium is mainly excreted by means of our fecal matter, that is calcium gets released, secreted mainly into the intestinal system, so that most of it will get excreted rather than being excreted in the urine. So GI system mainly play an important role in regulation of calcium excretion. Almost like 99% of the calcium is reserved or stored in the bone, and only 0.1% is in the extracellular fluid, and 10% is in the intracellular fluid. So only this 0.1 in the extracellular fluid. So uptake and release of calcium is mainly regulated the parathyroid hormone. We'll see about this in very much detail in our endocrine physiology. Here once let us see what it does. So actually parathyroid hormone stimulate the bone resorption. Means whenever the calcium is low in our body, what it does is try to break down the bone. So because of this, calcium can be released from the bone into the blood. But whenever in the cases like the calcium is low in our blood, when a calcium is high in our blood, then it tries to store more. So next one is stimulate the activation of vitamin D, and the parathyroid hormone, next one it does is it increases the renal tubular calcium reabsorption. So it can directly affect the renal tubular cells to absorb more calcium. Next, excretion. So by this we understand how calcium is reabsorbed, everything. Now let us see excretion of calcium, how calcium is excreted. Calcium is filtered, next it is reabsorbed. Only 60% can be filtered because others are plasma bound, right, ionized. Only non-ionized and free from plasma, they can only get filtered, that is like 60% is filtered. That too is reabsorbed, only like 1% of calcium is excreted out. So in proximal convoluted tubule, almost most of the calcium is absorbed here, mainly by paracellular route. Paracellular route means in between the cells, right? Only 20% is by transcellular route. And thick ascending part, 50% of plasma is calcium is passed by paracellular route and 50% by transcellular route. And even calcitonin, these hormones also increase the reabsorption mainly by thick ascending part of loop of Henle. And next let us see the phosphate. So especially whenever the phosphate is increased, the increased phosphate gives a signal to the parathyroid hormone to increase. Increase in phosphate also increases the parathyroid hormone, which in turn increases the absorption by the distal convoluted tubule and also thick loop of Henle to reabsorb more calcium. And if whenever the parathyroid hormone is low, there will be higher excretion of calcium. So whenever the parathyroid hormone is high, means it will say to reabsorb from the kidney more amount of calcium, but whenever the parathyroid hormone is low, it will say that to excrete more amount of calcium. So whenever there is low blood pressure, then the calcium excretion will also decrease. Why? Decrease in calcium excretion. Why? Because decreased blood pressure, actually calcium goes along with this sodium, all different ions. So whenever there is low blood pressure, means we try to reabsorb more sodium and more water to retain the blood pressure back. So even along with the sodium and water, this calcium also goes with it, so that whenever there is low blood pressure, the calcium excretion will be low because most of it will get reabsorbed. But whereas in the case of acidosis, you see in acidosis, we discussed before what happens in acidosis right here. In acidosis, we see a lot of calcium, less calcium is bounding to plasma protein. So here you can see in acidosis condition, there is increased calcium excretion because only some plasma is bound to protein, means free from plasma bound. So if it is not bound to plasma, it can easily get excreted out. So in acidosis, it is excreted out. Whereas coming to alkalosis, you can see low calcium excretion because in alkalosis, it's bound tightly with the plasma protein. So it can't get filtered out and also can't get excreted. Now let us see phosphate excretion, how phosphate will get excretion. Before that, I will show the diagram and explain about this calcium, and next we will move on to phosphate excretion. So here you can see whenever there is low calcium, it will mainly increase vitamin D3 activation and also it will increase the parathyroid hormone. So this both will in turn lead to increase in intestinal calcium reabsorption and also intestinal C, because from intestine most of the calcium is reabsorbed and also of course excreted by intestine. And also the renal calcium reabsorption will also increase whenever the pTH is high, and increased calcium release from the bones whenever the calcium is low, right? So pTH what is does that the parathyroid hormone does the bone resorption. So because of this, along with calcium, phosphate is also getting released into the blood. So this is the process. Next, here you can see how the calcium is getting reabsorbed, mainly in the proximal convoluted tubule. As I said, most of it is going by means of paracellular route. You can see this is a paracellular route, and some of it is going by means of channels directly, that is transcellular route. So from here it goes, and here with the sodium exchange, you can see they are like antipode, not sympode. They are antipode. As calcium is going outward, the sodium is coming inward, and we also have some channel active transport by means of ATP. Calcium is getting out into the renal interstitial fluid. So here you can see the factors which alter the renal calcium excretion, which decrease calcium excretion are whenever there is higher pTH, right, and whenever there is decrease in extracellular fluid volume, that will also decrease calcium excretion. Low blood pressure also decrease calcium excretion. As I said, as sodium, all those ions are absorbed, even calcium gets absorbed with it. And whenever there is higher plasma phosphate, whenever there is higher phosphate, also the calcium excretion is decreased. And in metabolic acidosis, and also vitamin D3 and parathyroid hormone, of course. But whenever calcium excretion increases is whenever low pTH, higher extracellular fluid volume, increase in blood pressure, decrease plasma phosphate, and metabolic alkalosis. Because in alkalosis state, we know plasma is not bound with the protein, so that it has higher chance to get excreted out. Now let us see the phosphate excretion. So mainly phosphate excretion, it's near to like that standard volume of phosphate is 0.1. So if it is the value of this phosphate which is present in our body is near to this 0.1, then most of it will get reabsorbed, because already low phosphate is in our body, so we need to reabsorb it, more of it. But if the phosphate value in our body is greater than this 0.1, then most of it will be excreted, because if now we are having lot of phosphate when compared with this value, right? So that phosphate will be excreted. So whenever there is low phosphate than this 0.1 value, then it will be reabsorbed. Whenever there is higher phosphate when compared with this 0.1, then it will be of course excreted, because it's excess. Next, you can say 75 to 80% of phosphate reabsorption is done in the PCT, especially that too by transcellular route, means passing by the cell. That too by means of this sodium phosphate co-transporter. We have a sodium phosphate co-transporter which takes sodium and phosphate by secondary active transport. We know this process. So by transcellular route it goes inside. And on the basolateral side of the membrane it has mainly sodium anion exchange. So by this method this phosphate gets out into the interstitium, and in DCT, DCT only 10% of phosphate will get reabsorbed and 10% will be excreted in the urine. So this is about the phosphate excretion. Next, this parathyroid hormone also shows its effect on phosphate, like in case of bone resorption, as the calcium is released into the blood, even this phosphate will be released into the blood. So the phosphate concentration increases in the blood, especially in the extracellular fluid. And whenever the PTH and PTH also, it decreases the transport maximum. Because of decreasing transport maximum, it will increase the excretion of phosphate. And magnesium, now let us say about magnesium. Magnesium is only 10 to 15% excreted from our urine. Here the proximal convoluted tubule reabsorbs 25% of magnesium. The primary site of reabsorption of our magnesium is done in loop of Henle. That is 65% of magnesium is absorbed in our loop of Henle. And these are the reasons for increased magnesium excretion. So these are the cases in which there is higher magnesium excretion, especially whenever extracellular fluid is having higher magnesium. Of course, if higher magnesium, we need to excrete it, and extracellular fluid volume is high, then also we'll excrete it. And whenever there is increased extracellular fluid, calcium, if the calcium is also very high, then we will release more magnesium, because calcium and magnesium are together are mainly reabsorbed at the thick part of ascending loop of Henle. So they both actually get reabsorbed mainly paracellularly by means of this potassium concentration, as it is making the tubule water impermeable, so they try to go inside. But if by means of any drugs or anything they are inhibited, the calcium concentration increases, and even along with calcium the magnesium also gets excreted. So this is all about the renal regulation of potassium, calcium, phosphate and magnesium. Here we seen how they are getting excreted out from our body.